Okay, we'll go ahead and get started in the interest of time, and anyone else who joins us will just be logging in a little bit late. So, hello, everyone. I am Jules Young. I'm a recent board member of SAEM. I just cycled off the board in May, and I am delighted to be hosting this webinar today. Today, we are receiving best practice updates on the management of agitation, the art of coordinated response, de-escalation, and pharmacotherapy. We are very happy that all of you are here and very happy to have our expert speakers to talk to us about this really important topic that we all deal with every day in the emergency department. So just a couple of housekeeping points. Earlier today, you received an email that included a link to the website that has the learning objectives and disclosures. Please refer to that at any time, and our presenters will review that information as well if you didn't have a chance to look at it. The webinar will be recorded, and the recording will be posted on our webinar page on the SAM website for future viewing. So it'll be available to you in perpetuity should you need it. Please, if you have any questions during the webinar, post them in the chat. We're going to allow our presenters to go all the way through their presentation first, and then we'll make sure to have time for questions at the end. If you have any technical issues, you can also put that in the chat, and we'll be happy to help you to the best of our ability. And I would like to ask that everybody who's not speaking, please make sure that you're muted and remain muted unless you are actually talking. So thank you again for joining us today. I'm very excited to learn from this great group. I'm going to turn it over right now to Dana M., who's going to kick us off.
Thank you, Dr. Young. We're excited to be here, sharing some of our disclosures from one of our speakers, which were also previously shared. We can move on to the next slide. So today we'll have a case-based discussion to review some updated research and evidence-based strategies for managing agitation and how to best care for this vulnerable patient population while also making sure that we are keeping our department safe and our staff safe. We'll be covering 4 domains that include early detection of agitation by verbal de-escalation, as well as trauma-informed care. And we'll also discuss medication management for agitation and workplace violence prevention. Next. And these are learning objectives. We'll be learning to manage patients who are agitated in the ED and also who are experiencing behavioral emergencies. And we'll be reviewing new and updated research on the management of patients who are agitated and presenting with behavioral emergencies to the ED. Next. So today's webinar will address agitation management from both the patient and staff perspectives, and we'll also explore how patient-centered management of behavioral emergencies and workplace violence are interconnected as 2 sides of the same coin, necessitating coordinated and balanced measures. And we have 12 speakers today, and in the interest of time, we'll have our speakers introduce themselves as we start each section. So diving right into the case, we have a 21-year-old African-American male who has a past medical history of schizophrenia who's presenting to the ED because of concern for paranoia as he's leaving his house during the night and staying in unlocked cars. And his family's really concerned that he might be using substances and alcohol with his new friends. Next. Past medical history is just notable for schizophrenia and 1 prior hospitalization, and he's supposed to be taking olanzapine at night. However, we're not sure if he's been complying with the medication. On arrival to the ED, he's tachycardic and he's hypertensive. He's disheveled, no signs of trauma, and he's unable to really follow commands to participate in a neuro exam. He's pacing around. He has grandiose thought and also labile mood, rapid and tangential speech. Next. So now I'll invite our expert discussants to review verbal de-escalation strategies and agitation detection.
I believe I'm first up. You can go to the next slide. My name is Dr. Lopez. I was the medical director of workplace safety at Boston Medical Center and recently relocated to Colorado. So all of us have had that patient, and I want to recognize that you have to go back to your ABCs. These are very scary cases sometimes. They're not only dangerous for our patient, but for our staff and for yourself. So recognize what the situation entails and where you are because each of our institutions has different amount of resources and no one to call for help in your given institution. I also do not think this is a patient that you should run up and try to do a detailed physical exam. All of the details that were mentioned in our physical exam, you could do from your 4 feet away. Observation tells a lot, and really look at how the patient presents. What are they doing? How are they interacting? Who's bringing them in, and what the circumstances will tell you a lot about your next few steps. Remember that you need to look out for red flags as far as medical etiologies of causes for agitation. That is really broad, and your approach will be different, and you will need to prioritize things differently depending on what you think is causing this agitated state. At our emergency department, we really advocate for common language. I don't care if that's Brasset. I don't care if it's bars. This is an example of the bars scale for agitation. It is a nice, quick, and easy 1 to 7 scale, which includes levels of sedation up until severe agitation. 4 is right smack in the middle. That's our calm and cooperative. I wish all my patients, and I wish for you that all your patients would be calm and cooperative, but we all know that's not reality. Every staff member should be able to de-escalate a mildly agitated patient, which would be a 5, independently. However, if your patient is persistently a 5 or popping up to a 6, which is moderate agitation, more than just one person should know about it. It should be a team effort, and you should call in the most qualified person to help with the de-escalation strategy and what our next steps should be. I advocate for a bars scale or agitation scale value to be right where your vital signs are. And this is because agitation is crucial, that if it is not addressed, the same as a blood pressure that's abnormal or a heart rate that's abnormal, it's not going to get better without someone addressing it. And that's really important in the moment, but it's a good communication tool. It's a good handoff tool. And it's nice to look back historically at how that patient responded to given interventions. So again, can't stress enough to record and communicate with a common language using an agitation scale of your choice. Next slide. Again, we're in emergency medicine. You got to pay attention to what those life threats are. How old is this patient? What are they going to come in with? Do they have signs of trauma? We all know there's a broad differential for tox metabolic etiologies of agitation, but really looking at what's in front of you and how they're interacting with the staff and the circumstances is helpful. This is also a case where it's really valuable to have someone at a computer workstation and pulling up their past medical history. Have they presented like this in the past? What has helped in the past? What's been the etiology in the past? So that you can act appropriately. That also gives us a lot of hints as to how they're going to respond to de-escalation. So I'm going to pass off to Dr. Rapolo to talk about de-escalation techniques.
Good afternoon. I'm Lynn Rapolo. I am a retired professor from UT Southwestern. I worked clinically at Parkland Hospital for 21 years, the busiest single facility emergency department in the country. And now I'm at John Peter Smith Hospital in Fort Worth. And I'm just sharing this with you. And next slide, by the way. I'm sharing this with you because these are busy emergency departments. And 8 years ago, I transitioned and learned about BETA, which is the best practices in the evaluation and treatment of agitation. And it's a series of articles written in the Western Journal of Emergency Medicine in 2012. And that's when I learned about de-escalation and what a powerful tool it is. And I want to mention and highlight, though, that by practicing this way and incorporating de-escalation and the BETA practices into what I see every day, and we see these agitated patients in the emergency department all the time. I have not had one physical assault on me or anybody I was working with in over 8 years. So I think that speaks for something, because I think it's something that we see all the time in the emergency department. So I just want to go over these steps. There's a very detailed article that's excellent, that's part of this BETA series written by Richmond et al. And it goes over these 10 domains, and I'm going to just briefly go over them. But so the first one is nonverbal communication. And we know that nonverbal communication is just as important, even sometimes more important than the words that come out of your mouth. And these patients are agitated for various reasons. This one in particularly has psychosis and he's paranoid. So you need to bring your compassion, your empathy, your caring face to approach him. And it starts when you first see him, and he needs to know that you're on his side and that you're advocating for him and not contributing to his agitation. So sometimes we have staff that just get in their faces and actually increase their agitation. So just be careful for that. Keep your safety distance, by the way. Respect their space. You want to be making like eye contact, of course, and just be very simple in your language that you care and you're trying to help them. Agree to what you can agree with. You don't want to say, okay, yeah, you are God. You want to just agree that he's unhappy or frustrated or uncomfortable or whatever. Define your boundaries. So if he's like starting to get really agitated and using foul language, just use those boundaries that they need to stay in their bed or else such and such might happen. But you want to just try to identify their feelings, give them choices. So these patients, especially these psychotic patients, need medication. So maybe you'll give them a choice as to, do you want it to have a shot of Zyprexa, or we can give it to you early, and giving them maybe a blanket or some food or somehow making them more comfortable with Zyprexa is such a wonderful combination. You can get them to partner with you. And then there's a debriefing of the staff at the very end, but it's another source. So let's go on to the next slide, because I want to bring this back to this case. So of course, this is a high risk situation. You want the most qualified person to be de-escalating. Again, you want to reduce any stimulation. If you can take people out of the room and but keep safety in mind, definitely focus on their basic needs. And again, trying to get them to agree to taking this medication because they definitely need it. But de-escalation, when you can do it, it has reduced my physical restraint and forced medication literally by 80%, and definitely reduces physical assaults in the emergency department. So now I'm going to hand it over to Michelle.
Hi, I'm Michelle. So I'm one of the attendings at Brown, and so we wanted to go on to the next slide to talk about how do we know if verbal de-escalation and all the nonverbal techniques Dr. Rapolo talked about is not working. I think we've all heard the phrase, insanity is doing the same thing and expecting different results. And so I think it's helpful sometimes to try and use those objective things like Dr. Lopez was talking, like the bars, where you're actually able to assess, has there been a change since we've tried these techniques? Dr. Rapolo talked about like the 10 de-escalation techniques. Have we actually tried the whole variety of it? I know in the next section, we'll talk about a lot of times there's opportunity for bias to come into play. And so I'll defer that discussion to the second group. If there is no reduction in that agitated behavior, despite using all the techniques at your disposal, then that might be a time to move on. It's also worth considering, don't anchor. Maybe the patient arrived in a place where we thought that verbal de-escalation was possible, but if the patient is actually starting to become threatening, more agitated to the point where staff and patient safety is compromised, then we would argue that's a sign that the verbal de-escalation, the nonverbal de-escalation is not working, and we might have to consider going on to other techniques. I think the second slide we wanted to discuss, next slide, was I think oftentimes we hear, well, how do you balance that need for the verbal de-escalation versus having such limited resources in the ER? We would actually argue that our agitated patients need to be viewed with as much acuity and priority, just like our patients who have chest pain, right? Or these like trauma patients. And I think it's actually a false dichotomy from the perspective of our team that it needs to be this, where are we going to expend these resources? Really, because a lot of the time these patients can be de-escalated and they will become more cooperative. And it's really when we're delaying that few minutes to try and talk to the patient, hear them, de-escalate them. It's really when we're pushing that conversation off that the patient can escalate to the point where we're not able to do verbal de-escalation, and that actually requires much more of a heavy lift from the team overall. I'll turn it over to the next section.
All right, continuing on to the case. You review the nurse's note that says, patient is saying what's up and flexing at the female sitter. Cannot redirect the patient, and patient is therefore placed in a 4-point restraint and received medication for agitation management. And the patient remains in restraint, and patient is unwilling to cooperate, no evidence of learning or willingness to work with staff. So these are what in the chart. So now I'll invite our next speakers to talk a little bit about patient-centered care in agitation management and how we can provide trauma-informed care and address these 4 questions.
Thanks, Dr. M. So my name is Ambrose Wong. I'm on faculty here at NYU Grossman School of Medicine and was recently on faculty at Yale in transition July. And Dr. Buckman and I are going to talk a little bit about ways to think about agitation management that is more patient-centered, and we can apply techniques in a way to help improve the relationship and therapeutic rapport with our patients. I want to start out by saying that this population, as the first group has said, is really particularly challenging, not only because they carry conditions that are difficult to manage, but they display violent and aggressive behavior that are really difficult for us to process and have to cope as staff members and as healthcare providers. And that can really create challenges and difficulties in trying to do things that are right for the patient or that are patient-centered. And of course, we're trying to do things that Dr. Lopez and others are working on to create both consistency and to apply best practices. But in the face of danger, these can be really difficult to apply. And we want to bring up some literature to show how sometimes the way we manage agitation may not be fully patient-centered, and then describe methods to try to combat that. So we want to talk a little bit first about how we manage these patients and how we think about when we, for example, when de-escalation fails, how we might apply physical restraints and sedation for these patients that are agitated. And I just want to highlight a couple of studies across the emergency medicine literature that have shown that the way we think about applying restraints may not be consistent across different populations. So two of the studies that were done, for example, at our shop here at New Haven Health have shown that when we look at the way we think about physical restraint placement in the ED, when we control for conditions that they have or potentially chief complaints for their presentations and or other clinical conditions, that certain characteristics may raise their risk or their association with restraint use. And this includes Black race, any housing insecurity, and also lower socioeconomic status, which is sort of indicated by insurance status. And also this has been validated in other systems, including a large healthcare system in Boston, and also studies have come out in other locations that have shown similar results. And this is a figure that our team has sort of hypothesized as ways that we think about how restraints and other ways that we manage agitation might be influenced by factors that are not necessarily within control of us as individual clinicians. And this is what we call a socio-ecological model that really identifies factors where agitation management and management of behavioral emergencies are being influenced in multiple ways with sort of overlapping circles. So everything from sort of the individual patient level where their underlying psychiatric history, the maybe thresholds for when patients might start having disinhibited behavior and violent behavior might be different. And of course, their socioeconomic environment. And this could be everything from them experiencing trauma in the past and maybe having a lower threshold to exhibit behaviors that could be seen as violence because of trauma experiences they've had before. And then the next level is at the staff level now, where it's really about the staff and their own experiences and how they may perceive threat and how they may think about empathy and be able to connect with patients, as well as working within teams of clinicians. So in the ED, especially managing agitation, we work closely with our nurses and security staff to work to manage agitation as a group, which may be different from other clinical settings. So that also really affects the way that we think about how we use restraints and how we decide on restraint placement as a team. And then, of course, at the institutional level, we think a little bit about the organizational climate and the culture in which we operate in, which may or may not influence when or how restraints are being placed. And also, we think a little bit about the training and the staff readiness for managing agitation and their understanding of protocols, as well as referral and services for us if we become victims of workplace violence. And finally, really the bigger picture are larger structures, social structures that interface with us, which affect how patients come into our ED and how they are viewed once they arrive. So for example, if they come with police, that might change the way that we think about these patients, depending on whether they have access to outpatient mental health services within the community. That might change how frequent they come to the ED and how often they display agitation. And then other needs that are really not necessarily health related, but maybe housing or food, our ability to work, might influence the way that they arrive at the ED and the way that we perceive their history of violence and their risk for violence. And so this is the study that really has shown where some of these upstream factors can potentially influence the way that restraints are being placed. So when we looked at potential factors that influence how, for example, Black race might have a higher association with physical restraint, despite being controlled for other conditions, we saw that really it's a linkage between Black race and the fact that they have higher odds of arriving under police custody or police transport, and that the police transport part of it is actually influencing how restraints are being placed in the ED. And these things are not really within our control in the ED. If they come in by police custody, we just manage them because they arrive as such. But that seems to have a direct impact on whether restraints are being placed even after they come to our doorsteps. And this is also another indication for where potential differences in application of restraint might happen. So behavioral flags are quite often used in departments, including our own. And this is really a helpful indicator in theory because it helps alert individuals that might be high risk of violence to staff before they interact with them so that they have a chance to be prepared for violence. And so that makes a lot of sense. But unfortunately, these flags may have downstream implications for how we manage agitation. So for example, in some of these studies, it seems like these flags are being disproportionately placed on, again, minorities and maybe those that have lower socioeconomic status. But afterwards, because these flags are in place, they may interface with longer wait times for a clinician to contact them, longer wait times be roomed into a room rather than the hallway, and potentially affecting on what treatment they receive in the ED, including imaging and testing that gets ordered during their visit. So thinking a little bit about these particular upstream factors that might influence how we manage agitation, I want to turn it over to Dr. Buckman, who can talk hopefully about some of these strategies to think about how we want to apply those best practices Dr. Lopez and their team have talked about in a more patient-centered way. And for example, going back to the case where the patient may have difficulty engaging, or we think a little bit about their unwillingness to learn, what can we do to help improve the way that we apply these practices?
Yes, thanks so much, Dr. Wong. Hi, guys. I'm Alice Bookman. I'm a colleague of Dr. Ims at the Brigham and Women's Hospital. So happy to join you guys today. And yeah, so what I'm going to talk to you today about is really how we can use trauma-informed care, this concept, as a framework for our interaction with agitated patients, and use it as a kind of a barrier that arms you against your biases, but also help anticipate how your patient's previous experience with bias might make it harder for you to de-escalate the patient. And one thing about using this trauma-informed care idea is that trauma is really universal. We think of bias and experience of bias as a form of trauma that in particular our patients of color are more likely to experience, but trauma is universal. And so this is really something to be universally applied with our patients. And it's a very subtle frame shift from seeing a patient who is agitated, annoying, really just disruptive and saying, what is wrong with you? To trying to take a step back and saying, what happened to you? And how has your past experience, how is that affecting how you're acting towards me right now? And then also thinking about what has happened to me. What are my past experiences with patients that maybe look like you or sound like you, or this happened in the same room? And how is that impacting how I'm relating to this current situation? And we're not saying you sit down and have a whole therapy session about this, but this is really sort of a quick check, almost a reflex that we're hoping to instill in our teams. One way to think about this is that there's like this big steaming cauldron of stuff that is sitting there between you and your patient. And both of you have put stuff in there, your past experiences, your biases, maybe the 30 other patients you're trying to manage. And you can't see everything that the patient put in there, and they can't see everything you put in there, but the vapors of that cauldron of steaming soup are influencing how you are seeing each other. And so trying to take a moment to kind of acknowledge that there is this soup between the two of you can sometimes help to really, again, sort of reframe how we're interpreting the patient and then how we can best react to what we're witnessing. And so one way to kind of think about this, and this says that it's a bias check, really, I think of this more as a trauma-informed care check, is this is just one algorithm that you can kind of walk through. And as our earlier speaker said, the first thing is safety first. We, unfortunately, are at risk in the emergency department of a fair amount of workplace violence. We want to make sure everyone's keeping themselves safe. So if there's an immediate risk of harm, then you need to obviously act. But if you can take a moment to, again, sort of reflect and try to get a sense of really think, what am I perceiving as threat here? What is the patient actually doing? Are they just pacing? Are they actually lunging at me? Would I perceive this as a threat in a same patient of a different ethnicity or color or age? And what about this is a threatening situation? And that kind of gets to number 2 as well. And then how is the patient perceiving? What threat are they perceiving? Because often agitation is sort of an exhibition of a patient feels threatened. They feel claustrophobic. They feel like something's going to get taken away from them. And trying to understand that. Maybe they've had a prior incarceration and the room you're trying to get them to go into feels like a jail cell. Those are really important things to kind of be able to think about. And then obviously, do you feel supported, and do you know how to get that support? One, I think, really exciting idea that I hope is not taken off the table by various budget cuts is the idea of using peer supporters to help as sort of mediators in this sort of understanding of the soup. So the idea here, and this is something that Dr. Wong and his group have worked on, is taking folks who can relate better to the patients, behavioral health patients, and having them really accompany the patients through what even in the best of cases is a really difficult interaction in the emergency department, and sort of help also to the providers to, again, kind of see what's in that soup and anticipate what is going to be, what's going to agitate a patient or what may help calm a patient, and seeing, and they're actually studying to see, does this actually work to help reduce episodes of agitation and reduce episodes of restraint? So lots of ways that we can apply trauma-informed care. And yeah, thank you.
Thank you. All right. So now, per collateral information, the patient has not been taking his olanzapine over the last 2 months. So therefore, the patient was placed on involuntary hold for further psychiatric care to be considered for inpatient level of care. And then upon learning this, patient became very agitated, attempting to punch the nurse and run out of the ED. So we'll now pivot to medication management of agitation. And I'm going to invite Drs. Martel and Wilson to address some of these questions that are on the slide.
So, hi everyone, I'm Mike Wilson, and happy to introduce both myself and my friend and colleague, Dr. Martel from Hennepin, and he'll give his views in just a moment. This is a really common scenario, and lately the questions we've been getting about this aren't so much which medicines to give, but more along the lines of question 1. Which of these medicines are given or considered chemical restraints? We know that because CMS, of course, has rules now that, or have had them for a while, but are being more enforced, that if you give chemical restraints, you have to do this, or you have to treat them as if they had a physical restraint. So let's talk about that rule briefly. CMS says if you are giving a medication, and that can be any medication, to manage behavior or to restrict movement, you are giving them a chemical restraint because you're doing it with the purpose of restraining that patient. That's a little vague. So they have some examples in their state operations manual for things that would be likely considered to be a chemical restraint. And those would be medications that don't have a really good evidence base behind them. Or, of course, if one of your staff makes the mistake of writing in the chart, I gave this medication to this patient so that he wouldn't move, or I gave this as a chemical restraint. Those are, of course, easy. So that's chemical restraints. I'll start off the conversation on number 2 and 3, and then I'll give Dr. Martel a chance to respond. That there's incredible diversity of opinion on what medications we should use, right? But there's actually pretty good agreement on medications that we shouldn't use. And so I'm going to concentrate on the medications to avoid. So what medications should you avoid in this patient? Avoid medications that would harm your patient. And you go, well, they're all good, but that's not entirely true, right? So we know if this patient comes in intoxicated with alcohol, we should probably avoid heavy dose of benzodiazepines, right? We know that if this patient comes in with a prolonged QTC or has a demonstrated QTC, and I'm certainly not suggesting that we get an EKG on everybody that comes in. I don't think you should either. The kinds of patients that have prolonged QT intervals or have a risk factor for having a prolonged QT interval, stay away from the medications that prolong QT intervals. Those are going to be most antipsychotics, but predominantly the first generations. Those seem to prolong the QT intervals a lot more than the second generations. And that's why most of your psych colleagues have moved away from first generations and moved into second generation. Dr. Martell, I'll invite you to agree or disagree or give your thoughts on that.
Mike, there would never be a time where I disagree with you. Might banter, but I think my perspective on chemical restraints is that in the emergency department, my goal is to always initiate and establish a therapeutic relationship with the patient. And so I would argue that I would even try some verbal de-escalation techniques and working with this patient to potentially get them to consider oral medications. But any medication used as part of your treatment plan to assist evaluation, safely manage the patient, and move them to the next step of their care is part of a treatment plan. I think I absolutely agree with Mike that there are medications that should be used less frequently, and everyone is going to have their opinion and various evidence behind them. But I think what's critical is that you're thoughtful about your individual patient. Folks will always come to us or me and ask me, what is the one medication that is the golden arrow here? And although early in my career, I searched and searched for that arrow, it really is very patient specific and hence patient centered. And I think that's the mindset. If you start in, you've already been working on a therapeutic relationship and initiated therapy for them. Everyone asks, do I need to get an EKG? And the answer is, I think that is absolutely absurd. I can't be any more straightforward than that managing the patient is our primary driver here. And so diagnostics, vital signs are all part of the second phase when you're now able to safely manage these patients. Mike, other thoughts?
You said it very well. I think we can sum up this section by saying the one thing people want to know when they come to an agitation lecture is exactly what you just said. What medication should I give them? What is the one combination I can remember and forget everything else? And I think you said it really nicely. It doesn't exist. You have to tailor it to the patient and their presenting symptoms and what you think the most likely cause of those symptoms are. And please don't write chemical restraint in the chart unless you mean it, and then you're going to treat it as physical restraints.
Great. Thank you. All right. Next part of the case, while attempting to bring the patient back to the ED bay, a patient assaulted the nurse and also punched the security officer, causing him to fall to the ground and his head hit against the wall. All right. So next part is on workplace violence mitigation. I'm going to invite our speakers to address some of these questions.
So, hi everyone, I'm Edie Thomas. I'm an assistant professor at Baylor College of Medicine and the assistant medical director for behavioral health initiatives for our primary training emergency department here. So this next domain will focus on workplace violence. You can go ahead and advance. So let's start with some statistics. This chart here shows the number of non-fatal occupational injuries and illnesses involving days away from work that resulted from intentional injury by another person in private healthcare and social assistant versus all other private industries. And as you can see, since 2011, the days away from work that resulted from assaults on healthcare workers climbed from about 8,000 to more than 15,000 per year. And then by 2018, our sector accounted for roughly 3/4 of all such cases nationally, making targeted prevention a priority. So now that we have recognized the problem with workplace violence, a number of professional organizations have started publishing data on the issue and putting out guidelines on how to address them, including the ones shown here with the Joint Commission and such. Go ahead and advance. But in terms of the evidence for all of these initiatives, we know that there are evidence out there for these efforts, but the quality is mixed. Most of the studies are quasi-experimental. They use pre-post designs and report heterogeneous outcomes as a result. We also know that multi-component programs seem to perform better. Effective multifaceted interventions commonly include clear policy, physical environment and hazard controls, adequate staffing models, and workplace training. And then implementation and how you do it is also a key difference maker. You have to have leadership involvement, dedicated resources, and clear outcome measures, such as data on staff injury rates, security calls, and restraint use. But overall, I think the caveat is that many recommended elements are still very consensus-based rather than proven within a trial or rigorous study. So there's still a lot of opportunity for research in this area. So this slide really focuses on signage and codes of conducts. It's important to note that the purpose of signage, policies, and codes of conduct are to set expectations and provide a framework for actions such as visitor removal, law enforcement engagement, and reporting. Zero tolerance policies often lead to our staff feeling very well supported, but evidence for reducing assaults are limited and also mixed based on the literature. And for us in emergency medicine in particular, I think EMTALA is our reality, right? So policies must preserve obligations for us to triage, screen, and stabilize. And while zero tolerance policies applies to behaviors and consequences, I think sometimes that's difficult for us in the ED because of our priority or our mission to follow EMTALA. And then another consideration with any signage and codes of conduct is like how we implement them. So when using signage, be considerate of any plain language, using multilingual signage in waiting areas to allow accessibility for all of your patients. And I think training and security presence, documentation, and reporting are also best practices to consider. So this slide mostly focuses on flagging practices, which was brought up a few slides ago by Dr. Wong. And again, the goals of flags is to inform and plan, and it's not really meant to be punitive. So flags should really trigger some sort of a safety plan and clinical strategies such as de-escalation preferences or environmental adjustments that you could use for that particular patient. Consider having a multidisciplinary behavior assessment or management team that could approach your flagging system. So this team would be responsible for reviewing events, setting the criteria for your flags, overseeing the care plans across different settings. And I think, as always, communication is key with implementation of flagging. So having standard electronic health record banner and handoff tools to communicate between inpatient and outpatient settings or different care settings to keep care consistent is important. And then, as mentioned before, with any flagging practices, it's important to be mindful of equity and good practice to have audits on who are getting flagged, like who of your patients are getting flagged, and for monitoring of any potential bias in labeling. And so now I will pass it on to Dr. McGuire for this next part.
Thank you, Dr. Thomas. I'm Serena McGuire. I'm an assistant professor of emergency medicine and EMS physician at Mayo Clinic in Rochester, Minnesota. Patient care plans identify high-risk individuals based on historic patterns of behavior, similar to the behavioral alerts in charts. The difference, though, is that these highlight key safety concerns and they provide some knowledge of prior triggers and warning signs from prior events with violence. They also recommend behavioral management techniques, communication strategies, and pharmacologic management based on those prior events with violence. And it's important that we know both what worked and maybe what didn't work, so we're not trialing or wasting time with ineffective strategies moving forward. Best practices for these care plans, similar to the patient flags, are to involve frontline team members for their input, to review them regularly for appropriateness and to expire them as needed, and then again to pay special attention to prevent bias. In terms of prediction tools for violence, there are a lot out there. This is just a list of a couple of them. I don't advocate for or against one particular tool. These kind of have some shared commonalities in that they seek to put an objective measurement on subjectively perceived behaviors, with some of these tools actually going a step further and incorporating medical diagnoses or current situations with the patient encounter, such as acute intoxication or a prior history of violence, which we know is quite predictive of future violence. And it puts a score onto that for that patient encounter so that you can try to predict escalating agitation and violence. I would encourage you to be familiar with these different tools and to see what might work best for you and your team in your particular care setting. I'll give it back to Dr. Thomas.
Thank you, Dr. McGuire. So This next part is about staff training. So we know that tiered training works best and it should focus on awareness for all staff. It should be very skilled based for frontline, especially for frontline emergency department teams, with consideration of advanced content for code response leaders. And as with any training, I think refreshers every 6 to 12 months to maintain skills is important. There are quite a number of established frameworks that you could use, including ones from the Joint Commission, and the Emergency Nurse Association has a curricula, as well as the TEAMS programs listed here. And the World Health Organization also has some guidelines that you could follow. And an important point to make is that while there are plenty of staff training materials available, there is a lack of training for physicians in particular. And so I think to mitigate some of this, consider embedding training or using some of these existing modules and geared it more towards physicians and included in onboarding processes or any required annual training that you may have for your institution. It's also helpful to provide training through simulations as a tool to teach them, allowing your participants to practice de-escalation techniques, closed-loop communication, safe restraint practices, and any legal or documentation requirements. And then, as with any training, it's important to measure impact and if the materials are being taught are actually being applied in real life. So tracking clear outcomes such as the number of assaults that are happening pre and post training, staff injuries, restraint rates, and reporting compliance are key considerations. So this is a slide about team-based approach to agitation management. And as we've mentioned briefly before, having a team-based approach is good practice. This is an outline of what a code response team may look like with pre-assigned roles. Like any team, there's a team lead who assigns the roles for your team members, enforces like closed loop communication, and oversees general safety. Another key role is the communicator role. This person is providing a single voice to the patient and is really working with that individual to build rapport. And then your clinical staff will assist with preparing and administering medications, monitoring vital signs, placing IVs, obtaining labs, and also just monitoring for the patient's safety. And then it's also good practice to have a security officer present who can assist with preparing and administration medication or restraints, also crowd control to help protect patient privacy. And the figure to the right is just an example of suggested positioning for your team. You can see that the team lead is at the foot of the bed and other team members are around the bed. And it's also good consideration to have extra security and nurses outside the room on standby if needed. Overall, studies have shown that implementing a structured code response team has been associated with about 30% reduction in physical restraint use in the emergency department. And I will hand it back to Dr. McGuire.
Next slide, please. So unfortunately, this wouldn't be a comprehensive discussion on workplace violence if we didn't talk about weapons. There are two types of healthcare-based shootings and stabbings, but we most often see shootings applied. These are targeted, where the perpetrator has a planned target in mind, often a healthcare team member or healthcare team member or the actual team. And this perpetrator comes in concealing the weapon with the intention of harming someone in particular. We recently saw this in February with the UPMC Memorial Hospital shooting, where a husband of a patient who died in the ICU returned to the ICU and then targeted the ICU team. This is compared to a fit of rage shooting where it's unplanned, the individual has a weapon on them in the healthcare setting, and then something happens and they target victims in close proximity. And an example of this would be the Dallas maternity ward shooting in 2022, in which a boyfriend of a laboring patient accused the patient, his girlfriend, of cheating on him, assaulted her, and then stated, "The next person to come into this room is going to die with us today," and proceeded to murder the next two healthcare staff members that walked in, which was a nurse and then a social worker checking on that nurse. These different types of hospital shootings or stabbings can potentially be mitigated by weapons detection systems, and we're seeing an increased prevalence of weapons detection in the healthcare setting over the past couple of decades. And we've switched from traditional metal detector screenings to now emerging technology, which includes passive weapons screening, such as you can see here. The thing I would like to emphasize, though, is that we do not, despite weapons detection screenings, operate or practice in a weapons-free setting. Depending on the sensitivities these are set to, and depending on if you have EMS arrivals being screened for weapons, which you probably do not based on the limitations of this technology, you most likely still have weapons in your workplace, and that's really important to keep in mind. It's also important that we recognize that we do not practice in a silo within the four walls of our hospital. We practice within a larger community, and things that happen in society spill into our four walls of our hospital. And so it's important that we collaborate with public safety services. And we talked about this in the comments with some questions. And in our own institution, we have a community collaborative that meets monthly with representatives from all of these departments and services. And we talk about mutual concerns and issues that we all face because things that are happening outside our hospital continue to happen longitudinally into our hospital walls as well. And it's important that we all collaborate with each other to solve our issues that are at hand. And finally, I'll just end with a quick statement on the role for advocacy in this important topic, making this important issue known at the highest level of government and advocating for it to be addressed, and supporting legislation that addresses it to protect ourselves and our staff members and our patients as well. Thank you.
Perfect. And I think that wraps it up. So maybe we can take down the slide and spend the next 8 minutes addressing any questions from the audience.
So we had a number of questions in the chat, and you're such a large and thoughtful team. You guys were really getting a good conversation going there. But maybe, for people who were not reading the chat, maybe we can talk about a couple of these. So one question was about implicit bias. How can we discuss implicit bias with those of our colleagues who don't believe that it exists and who may be insulted by even the implication that it may exist, and therefore indirectly be present in them? So how do you confront that topic with people who are implicit bias skeptics?
I can take a crack at answering that, at least to start the conversation. I apologize, my internet is a little choppy. So I think my approach to it is that it's really about how you frame the conversation. That's sort of how I think about it. Especially, I feel like in the modern times, when we bring up concepts like equity and bias and disparities, it can raise, I think, some concerns and people's defenses can come up. So I think it might be a better conversation to say, these are patients that we're trying to care for. They're particularly challenging patients that we are caring for. How do we create an environment that really improves their experience while keeping ourselves safe? And thinking about discussions really about the larger forces that are at play that cause different people to potentially receive treatment in different ways. I think the other thing is it can really create the sense of the other when we talk about bias, meaning like it's us versus them, patients versus staff. And I think it's because both sides, meaning the patients and the staff, can feel victimized by these interactions. The patients are being forced to be there against their will, and we're being forced to face with violence against our better judgment and the fact that we don't feel like we should tolerate that. So I think that can really create that feeling of tension and maybe direct conflict. So sort of, I think what Dr. Bachman was getting at is the soup is a good analogy. We're all living in a situation where there's active trauma, in a situation where there's violence and agitation, both staff and patients. But we have aligned goals, which is how do we minimize the amount of negative impact on staff and patients while we take care of patients as best we can. I think if we find that alignment, it's a better conversation. So are there things we can do that will make sure that staff are safe, which are limits we need to draw, and things we can do proactively while we can make the experience better for the patient? And I think, honestly, the best way to really deal with it is, as attending physicians, which are all of us on the call, that we take leadership roles in being proactive to manage these and mitigate potential escalations. And I think the earlier we can do it, the better we can provide the best practices that the first group was talking about. So that's sort of my own personal feeling on it. But any thoughts from others?
Yeah, I think that's exactly right. I think really, maybe this, I'm too conflict averse, but I've never found a situation where saying to somebody, I think you're being biased, has been helpful, or it seems like it would be helpful. I think rather trying to take a step back, saying, empathizing with the person, because usually, as Ambrose said, like, this is a really crappy situation to be put in as a frontline nurse or tech or training physician to feel unsafe. To empathize with that And then to sometimes maybe model empathy towards the patient and thinking, gosh, I wonder, what it's so hard to be unhoused in this situation, or, I can only imagine the amount of trauma that this person has gone through, something just to sort of, it's sometimes I find that works where people are just like, oh, okay, let's just try and humanize everybody, because that's really what we're trying to get around. We're trying to get around the dehumanization that these biases cause us to do, and to really be able to see our patients more fully.
Now, I think I would highlight modeling, debriefing, taking the opportunity to talk about a case as was suggested, and then encouraging particularly our trainees to share feelings that they have in those situations, because I think they become more mindful when they recognize the triggers in them. And so those are the three things that I feel are probably most effective, but again, more at the trainee level.
Okay, that was great. I'm going to ask one other question from the chat because I know this is one that we've all dealt with. How do we de-escalate when the patient's agitation is a direct result of loss of agency from our medical decision to keep them in the ED for safety concerns, such as if they are suicidal and cannot leave, or are intoxicated and need a sober reevaluation? So, in other words, when the conflict is us keeping them there against their will, how do we approach de-escalation in that situation? And that's one I've certainly struggled with myself.
I think you're continuing de-escalation during the conversation with them, because they're, sometimes you just can't make them happy. But I think, just like anything else, trying to empathetically and compassionately just educate them that it's a risk for letting them go. But I just kind of blame somebody else that's outside of us, such as legally, we cannot discharge them, and just doing our best to meet their needs while they are there. But sometimes that just doesn't work, but you just try to pull all your, whatever you can to try to diffuse that degree of just negativity and agitation and their frustration. And sometimes it helps.
I'll jump in and say I agree with everything Lynn just mentioned, and following on Dr. Buckman's excellent comments a minute ago. What can be said, there's lots of things you can say. You probably should avoid saying things like, it's your fault, or if you hadn't have told this to the triage nurse, then, and I think an honest conversation on the exactly as Lynn just mentioned is the way to go. Hey, I know this sucks, but I legally can't discharge you when we're concerned about your safety.
I would also just add that quickly following that up with, and I can't imagine how awful it is to be stuck in this windowless room for an unknown period of time. We want to get you out of here just as fast as we possibly can. In order to do that, we need to work together to keep you calm. If it were me, I'd be crawling up the walls and would love something to help calm me down. What can I offer you? And so really trying to kind of switch it to, what can I give you? Can I give you food, blankets, Ativan, whatever, to try and smooth this over and normalize the fact that like they're freaking out about being stuck against their will is a completely normal response.
Well, I think we are almost at time right now. This has been a fantastic discussion, and I really appreciate our presenters. You guys have been amazing. But I think that our time together is now coming to a close. Please, everybody who's on the call, please complete the webinar evaluation. You'll receive that afterward, and let our presenters know what you thought. Thank you very much.
Thanks for facilitating, and everyone for joining us today. Have a great day.
Everyone have a great rest of your day.
Thank you.